Mhm. Hmm. Takashi,
Hey, good evening. Yeah,
Takashi, you want to moderate?
Murray,
Yeah, you can introduce Ramesh Nair. Do you want to?
if possible, so I can try to. Yeah, Ramesh
Okay,
Nair. So,
yeah, just look at his resume real quick, okay? And
okay, resume.
yeah,
China neurosurgery.
look at his resume, and I'll introduce you, and you introduce him, okay?
Okay, today the lecture with Ramesh Nair and consultant neurosurgeon, Charging Cross Hospital, London, England. He has a great contribution to world neurosurgery, and his CV or some other. And
Yeah, just pick out
introduce
what you
Ramesh
think is
Nair.
right. Yeah, whatever think is right. You just introduce him in a good
Okay,
neurosurgical way.
neurosurgical West.
Yeah,
Okay,
introduce
so
yourself. Introduce yourself. I'm Takashi from Japan,
oh yeah, and
and your goal is to travel the world with me
yeah,
to tell
yeah,
about neurosurgery webcasts
yes,
from the mountains of Uzbekistan to the
Uzbekistan
deserts of South of
desert.
Africa.
Yeah. So his resume. So I tried to look for his resume, and I introduced Dr. Ramesh Nair from England.
Okay,
His CV as far as consultant. He is a consultant neurosurgeon at Cromwell Hospital, and
okay,
his clinical interest is scar surgery and is endoscopic transsphenoidal surgery for pituitary and scar tumors. And he has a great contribution award neurosurgery. And he also was a member of IANA and other faculty, IANA inviting faculty. IANA, Imad Kanan can lead IANA, International Neurosurgery Anatomy of Neurosurgical Association. And he will
okay.
give a lecture. He will present today endoscopic transcriber approaches avoiding complications. Dr. Ramesh Nair, please. Like that.
Sounds good.
Okay, so I met Binsu in Tokyo last Friday.
Oh, you met Ben in Tokyo.
Yes, directly. Ben and Sachin and Ruben-san directly.
Was that
And
the first
Ben
time?
NG is, yeah, this is first time in Tokyo. And this is Ben MG from Hong Kong. Ben.
Okay. Yeah, he's in Tokyo. I think he's in Tokyo now. I'm not sure.
Tokyo, okay.
I think
Hong
he's
Kong
in
University.
Tokyo.
So yeah, this weekend I fly to Hong Kong for traveling.
Oh, okay.
Yeah.
Oh, okay. For a
I
conference in Hong Kong?
no. I also won the ticket from Japan to Hong Kong. Free ticket.
What?
And try to, yeah, only 3 days, but I got a free ticket and from Okinawa to Hong Kong.
Oh, okay. You've been to Hong Kong, right?
Yeah, so I try to visit Hong Kong this weekend. So
Okay.
yeah, so this Neurosurgical TV, so I'll introduce Ramesh Nair, and
Well,
sometimes I try,
here he is now. Here he is now.
yeah, practice. So this time, so I'm Dr. Takashi Kon, Showa University from Tokyo, Japan. Today, invite a lecture. I invite a lecture. Introduce Dr. Ramesh Nair,
Hello,
our
Ramesh.
consulting.
Thank you.
Ramesh.
Hello,
How you
Takashi. How are
doing?
you?
Hello.
Hello.
Good evening. Good
Yeah.
evening.
Do
Yeah.
you know Takashi?
I know him
Yeah.
because he was a regular participant in our meetings, long time.
Yes.
So know him very well.
Yeah. I So yeah, I learned a lot. And you visited Dr. Dr. Fujita and
Yes.
yeah, Imizu. Yeah, Shue, Imizu.
Mister, yes.
No, yeah, Imizu Shue. I'm
Very
a
good
friend
friend.
of mine. Yeah,
Very
very
good.
good friend, Dr. Imizu. Yeah. So I'm waiting for the good, exciting. So today I introduce Dr. Ramesh Nair for this meeting. So you're Cromwell Hospital, Cromwell Hospital.
Yeah, that is my private hospital I work, but I also have a main hospital which is different.
Different. Okay.
What hospital is that?
Okay. What's that?
Could you tell Takashi what hospital that is?
So it's called Charing Cross Hospital.
Charing Cross Hospital.
It's part of the Imperial College Healthcare Trust, which got many hospitals, including Charing Cross and St. Mary's, and there are a few hospitals, and these are the hospitals where I work basically. But Cromwell is another private hospital I work sometimes.
Charing Cross Hospital, and London, England, and Cromwell Hospital.
Yes, and also some other hospitals as well, but these are the main hospitals.
Yes, the Cromwell is
Private.
so very historical person.
Yeah, he's a historical person. Yes.
Yes, reform, and yeah, I learned the history.
Okay.
Yeah. So today I will lecture, and I'm looking forward to seeing the transcribal approach endoscope surgery and avoiding of skull-based surgery. I'm very interested in including neuroanatomy. Thank you.
Thank you. Shall I start sharing the screen in that case?
Oh, we're not ready yet.
Yeah.
We're not ready yet.
Okay.
A few minutes.
Sure.
And Dr. Ramesh, so I want to try to use Zoom for English-Japanese simultaneous translation. So if you don't mind, so I will use in small voice, sometimes Japanese. So sometimes if you're annoying, I'll do it, unmute, because this is only a trial, Zoom trial.
Okay. Yeah, I know that previously when John did this meeting, I saw that there was a simultaneous translation to Russian. Is that right?
Russian, yes.
Yeah.
Sometimes there is. It depends on what we pick. I'm just getting to know this program, really, Takashi. It's tricky. It's tricky.
Because
It's
on
okay.
the lower panel, you can see that you can show the captions. That what you use on the
Yes.
Zoom? Yeah.
Yeah,
Yes.
if we try to use the caption in another language, or sometimes just
Yes.
in English, for people that don't have a good grasp of oral English. You know
Caption
how
will appear.
some people can't they can read it, but they can't understand it spoken. You know what I mean? So it doesn't hurt also to have it in English if it comes to that.
Yeah.
Yeah, I think
Okay, let me show you. Let me show you guys what we do here. This is the way we promote. Here's what we do on LinkedIn. I think you've probably seen it, Ramesh. You see this?
Oh,
I can see it. That's your WhatsApp.
You can see it?
Yeah, I can see it. It's your WhatsApp screen.
Yeah, this is WhatsApp is a great way to publicize what we're doing.
Yes.
Because we have now live and it's easy for people to jump in.
Yes.
So try to make it as easy as possible.
So I can see a lot of groups on your sidebar. It's I don't know how neurosurgical.
About 50, but there are some as I miss, some I don't have.
Okay. Yeah, that's fantastic.
You've probably seen a lot of them.
Yeah, I like the last one on that screen, Neurosurgery Mumbai Mafia. That is a
Oh,
good
yeah,
one.
yeah.
Oh,
well,
yeah.
Atul and his boys.
Nice. Yeah.
We'll start in a.
I'm also part of some of these groups, I know.
Yeah, so you see the adverts, right?
Yes.
Okay.
I have seen the advert on the WhatsApp group, on your
Good.
WhatsApp group. Yeah.
Good. Okay, we're ready to start. Okay, 10. Let me just get everything, make sure everything's ready. I don't do that sometimes.
Okay.
There'll be more people joining in as we come. Okay, 10, 9, 8, 7. You know, hold on. Let's wait a minute or two for Juan Lee.
Okay, one day.
Okay, yeah, Juan Lee is not here.
Okay.
Let me just give him a second.
Is Shiva in there? Okay.
No, Ben is in Tokyo. He may join it. He may join us by
okay. He's in Tokyo, and I met him on Friday. I met him on Friday.
Yeah, first time, huh?
Yeah, directory. I met him on Friday.
Did he speak in Tokyo?
You've been saying?
Was it a conference that he was at?
Yeah.
Yeah, let me get Juan Lee on WeChat. He likes WeChat.
Okay.
Okay, well, we can start because he really introduces the second speaker. Okay, so we'll start. Okay. Hello, Mohammed Helmi. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach, home of Neurosurgical TV. We have the honor of televising the China Neurosurgical Journal with Ben Zhu. He's in Tokyo. He may join us later. Today we have the moderator Takashi Khan, a gentleman after my own heart, Someday we're going to travel the world, Ramesh, and just do conferences of neurosurgery in all parts of the world. I'd like to introduce Takashi to introduce Ramesh.
Yeah.
Welcome, Takashi.
Thank you, Dr. John Bennett. I'm Dr. Takashi Kon from Tokyo, Japan, Showa University. I'm a neurosurgeon today. I'm joined, so I will introduce Dr. Ramesh Nair from England, London, consulting neurosurgeon, Charing Cross Hospital and Cromwell Hospital. So he had he's specializing the scalpel surgery and many experiences and many contributions to the INA or WFS in the world. And today he will present a lecture of endoscopic transcribal approaches, avoiding complications. Dr. Ramesh Nair, please.
Thank you. Thank you, Dr. Takashi Kon, and John and Binsu and the China Journal Club for this invitation. It's a great honor for me to speak to the audience in Japan and China and worldwide. I would like to speak about the transclavial approaches and how to minimize the complications possible. I'm going to share the screen first, and so let me just share the screen first. Are you able to see the screen?
Not yet. Okay.
Yeah. Are you seeing the screen?
Yeah, seeing the screen. We don't see the PowerPoint yet. Okay. Yes.
Is it okay?
Yes, we see it.
Okay. So I work at the Imperial College Healthcare NHS Trust, which is one of the biggest trusts in UK. And this talk is mainly a technical talk in terms of how to avoid complication in endoscopic skull-based approach for removal of lesions in and around the clival bone and also inside the clivus and intradural lesions as well. And I will take you through some of the issues when we deal with such cases. For example, this is a standard transfemoral approach. Majority of approaches aimed at the sella here and the tuberculum and the planum here. And we are familiar with the carotid artery on either side and the optic nerve on the other side. But for a transclavial approach, you only see the upper third of the clivus through this approach. This is the floor of the sphenoid fossa here. So if you really need to go below that level, you have to go and drill off this base here to get under to see the lower half and the inferior third of the clival bone. And also the vision is often restricted by the bony shelf. So to have a bimanual approach and maneuverability of the instrument, one need to have a wide exposure outside so that you have enough space to move your instruments around. And the operation happens between the two carotid arteries. Traditionally, as you know, that we've been operating these lesions with other approaches coming from the side or from the front. For example, if you have to operate around the petrous, the top of the basilar bone or a posterior clinoid, we often use a subtemporal approach or a frontotemporal orbitozygomatic approach, which are very standard, well-established routes for this upper clival lesion. The lesions between the petrous apex and at the level of the internal meatus, which is almost the upper half of the clivus, you often have to come from the side, either through a petrosal approach or one of the transpetrosal approaches. But lower down, you can come from taking the posterior petrosal approaches below the seventh nerve complex and between the internal acoustic meatus and the jugular foramen. So these approaches often takes a long time to drill off the petrous bone and navigate the corridors between these neurovascular structures. Of course, we know that anterior lesions often will have to take a lateral approach through the foramen magnum, like a far lateral approach or extreme lateral approach, either drilling off the condyle or even displacing the vertebral artery to one side. So all these lesions can be tackled by a single approach from top to bottom. That is the advantage of the transclavial approaches, but there are some indications, and one has to be very selective in terms of deciding what approach to take take for a particular case. That depends on the nature of the pathology and the condition of the patient. So that is how it's a case-to-case basis. So you cannot just have a dogmatic view to say that I'll only use particular approaches, particular kind of operation. So one has to be flexible and has to remain very open about the kind of approach you use for each case. And the limitation for this approach is often the bony landmarks you have in and around the nasal cavity. For example, to come to the top of the anterior cranial fossa, the anterior extent, your access is limited by the upper maxilla here, and also the vision which you get. This is the kind of line you get. Lesions behind the frontal air sinus, it can be tackled, but for an intradural lesion such as meningiomas or other lesion, you may find it difficult to get a good excision. So often you may have to come from cranially. But beyond that, you have a straight view from the anterior cranial fossa towards the planum and the tuberculum, the sphenoid sinus, the sella fossa, and also the posterior clinoids, dorsum sella, the upper and middle and lower third clivus. But going below that, to come below that clival bone, you may have to angle the endoscope so that your mobility is restricted by two bony factors. One is the nasal spine here and the hard palate. So that is, will explain your the access for such cases. Let's see the anatomy in a cadaver specimen here. So this is a normal transsphenoidal approach we use. And most of our operations are within the space or in the space where you operate on pituitary gland or operate on tumors in front of the pituitary gland. And the most important anatomical structure one will have to get an orientation about is the way the carotid artery is placed in the skull base. Once you master this anatomy, once you know how the carotid artery is traveling in the skull base, you can master this operation. And it's all about understanding and having a three-dimensional orientation about the way the carotid artery travels through the skull base. As you can see from this, that the carotid artery within the cavernous sinus has got a genu at the back and also the front. And these are fairly medial, and then it loops slightly laterally. So when you operate on this area here, your risk of damage in the carotid artery is slightly less. But when you go anteriorly towards that opticocarotid recess or lateral ends of the tuberculum, the paraclinoid artery comes very medially. That is where one can cause carotid damage, because carotid injury during such an operation, it's a major complication, and often it can end in fatality and a catastrophic event, or even occluding the carotid, having to take the patient to interventional radiology suite, or even occluding the carotid, which can lead to major stroke or other complication depending on the nature of the collateral circulation. So one has to know where is the possibility of maximum damage to the carotid artery when you're doing a skull-base operation. For example, here within the cavernous sinus, after this loop, which the inferior part of the loop is slanting that slightly laterally, so you are safe unless you go very laterally to go to the middle cranial fossa. But here, as you come down, where the cavernous carotid transitioning onto the paraclival carotid, that is also medial. So this artery and this paraclival carotid artery on either side usually will be a lateral boundaries for a transclival approach. And to access the upper clivus, this is hidden by the pituitary gland. So to get to the posterior clinoids and the dorsum sella, one will have to lift at the pituitary gland. We'll talk about the ways to do that in due course. And coming to the lower part, if you really want to see the lower third of the clivus, you'll have to come through the floor and drill off the lower wall of the sphenoid bone, including the floor. And at that level, the level of the floor, you can see that the carotid will again deviate very laterally. So this is the length of the paraclival carotid, and from there the carotid moves laterally. So if you can go a bit more laterally here depending on the axis. but that will be the level of the foramen lacerum. And to go laterally, you need some more slightly angled approaches to get to the under the foramen lacerum. Below the clivus, if you take more, go towards the nasopharynx and remove the mucosal bone, mucosa around that area, you can see the edge of the foramen magnum. But this is where you have the arch of the LS, anterior tubercle and the arch of LS. Behind it, you will have the atlanto-odontoid joint. So this is huge, and below that is you have the hard palate, and the angle is quite difficult to get to. But this is the extent one can reach with the endoscope. So let's look at the view once you remove the clival bone. You can see the paraclival carotid is your lateral extent. One has to be careful once you get to that extent, depending on the pathology. Say, for example, if the pathology is infiltrating the bone around here and more laterally, one may have to deroof the paraclival carotid so that you get more, you can mobilize the carotid slightly more laterally to get access to the pathology. And beyond that, the foramen lacerum and the petrous carotid will be much lateral. And drilling of all this will get you to the lower part of the basilar artery, including the vertebrobasilar junction. So this is, to access this region, one has to come very low down onto the clival bone. So you have to get very low enough, including the nasopharynx, to expose this area. And the two main nerves which you will be coming across in an operation around the clivus, especially when you do a fan clivectomy or when you resect the majority of the clivus. The common nerve intradural you come across is the sixth nerve, which travels through the cisternal space and then enter the upper part of the clivus to go into the cistern and then go into the cavernous sinus. So it enters through the Dorlus canal, and these are the intradural structures you will be seeing. But also, once you lift up the pituitary gland, you can see the petrous apex. You'll see the basilar apex with the bifurcation. And you'll also see the third nerve higher up. So these are the structures often encountered during a transclival operation. So to understand, to avoid complication in such operation, one has to understand the commonest neurological, neurovascular structures one encounters. So let's show, this is a picture from Barrow. You can see after the paraclival carotid, it turns laterally under the at the foramen lacerum level, and then comes under the skull base. So this is extracranial here. Extracranial, this will be just lateral to the eustachian tube. So also I'll just go back and show you where we found the eustachian tube. So when you come to the nasopharynx, on either side of the eustachian tube, just remember that the carotid artery will be extracranial, lateral to the eustachian tube. So this is where you don't really have to expose it, but that's the level of the carotid artery. So that is the course of the carotid artery. And understanding and studying the carotid artery direction and travel in the skull base in a particular case is so important that you can keep that in your mind all the time so that you will avoid damaging it. And the basilar artery, they can see that it can vary in many patients depending on the age. There may be big loop, and maybe one vertebral artery may be dominant at the other side, and it may be quite ectatic and go to one side. So tumors may displace to one side. Tumor may go between the basilar artery junction. So I'll come to such a case fairly soon. And we have talked about this is what I'm talking about, the sagittal plane. Coronally also you can go laterally, especially in some chordomas which go into the middle cranial fossa. One may have to think about the implications of the neurovascular structures. But in altogether, endonasal approaches give you a very direct view. You're not closing you're not traversing the neurovascular structures to remove the tumor. That is the beauty of this approach. But I agree that it is not something which you do for every case. It's a case-by-case basis. And when do you do this sort of approaches? What are the indications? And I'm not going to list a long list of indications, but the common conditions you see, I'll present some representative cases from the recent past to show you what is done for such cases. But in general, anything from the upper clivus, tumors around the dorsum cella and the posterior clinoids, and sometimes the pituitary tumors, when they are extensive and spilling behind the dorsum cella into the posterior fossa, you can use this approach. But also common conditions such as chordomas, which are mostly midline, sometimes can be lateral as well, can extend from the upper third to lower third, but often come from that spheno-occipital synchondrosis, which is the commonest location for cranial chordoma. But also lower down, you can also get tumors like chondrosarcomas and tumors inside the dura, which is often meningiomas in such a location, especially lower part, in the lower foramen magnum or near the Atlanta-Odendaur junction. These are kind of lesions you commonly see to employ these transclival approaches. And there will be some other unusual conditions where you may have to consider transclival approaches, or conditions around the petrous surface, cholesteatomas, and some bony tumors from that locations. And what about intradural lesions? Intradural lesions could be either within the vertebral basilar system, aneurysms, or brainstem lesions occasionally, or exophytic brainstem tumors to get biopsy or to debulk. And these are unusual indications, but I'll just show you some of the cases. This is what I meant by the extent you can employ this transclival route. For example, this arrow shows you from the nasal bone and the hard palate. And you're not able to go beyond that. You can come to the C2 here, but also include the T1 arch and in the dens here. So all this area can be accessed with your instrumentation here. I've mentioned the usual indication. Let's see one case. This is a man who was in his mid-70s. He was being monitored by another team in the department, and for some time he was fairly well with this tumor for some time, but for the previous few months he was getting more and more symptomatic. And these lesions, obviously you can see that it is durally based inside the posterior fossa, wide basal attachment, and it is pushing onto the lower part of the brainstem. And the symptoms are related to ongoing compromise of the brainstem. He was getting incoordination in his upper and lower limbs. He was finding it difficult to walk. And given his age, obviously it was sensible to see how things are for some time, but then he will reach a stage where his quality of life will be affected. This is the time when to consider surgical resection. So this is a case was referred to me, and I decided to consider an endoscopic approach to debulk the tumor. Intentions are very clear in this case, to get maximum tumor out as much as possible, but also at the same time, you're not planning, we were not planning for a radical resection. We want to give him symptomatic improvement and to remove maximum tumor as possible. But the one thing about such cases is that in this case, in the lower part of the vertebral basilar junction, the vertebral basilar fork, where the two vertebral arteries are joining to form the basilar artery, and the tumor is just tucking in under that the vertebral basilar junction, and also projecting into the medulla. And this is the reason why he was getting symptomatic, and also it poses a surgical challenge to remove that tumor at that level, and that will be the main intention. With such cases, it's important to plan how you want to do it. You should have a strategy to take this tumor out and get as much information as possible, including maybe 10 years now, and the crude model of the tumor by the 3D printing, you can see that the tumor is sort of going behind the vertebral basilar junction. And one can see that the navigation will tell you the way the vessels are displaced here. And you can see it is fairly anterior. Sometimes when you see tumors in the foramen magnum, it's often laterally placed, which gives you an option to consider a lateral approach. Even though this can be tackled through a far lateral approach, this may be a better option if you're planning to do a significant debulking. You can see that this is the nasopharynx, and we are below the sphenoid sinus. This is the cavity of the sphenoid sinus. It's opened up, and this is the cellar floor. This is the sphenoid sinus floor here, and you can see that flap is being harvested by the ENT colleague. We often do this extended endonasal approaches and other endonasal approaches with the ENT colleagues, and we work as a team. So team approach is a great way to have input from both teams, and also excellent follow-up of patients by both teams. So that is the inferior pharyngeal flap, and the extent with the navigation tell you how far you can reach. You can see that the upper and lower limit you can mark out, and that should be enough to give you the here the midline pharyngeal mucosa is being removed. There will be a median raphe, which is going to be quite thick, and you clear up all that, and you have obviously opened up the sphenoid sinus, and also this is the nasopharyngeal bit, but you're drilling the lower clivus here. That clivus usually is very thick. In upper clivus or mid clivus, sometimes you can see a well-pneumatized venosinus and a little bone to drill. But in a lower clivus, you see a very thick bone, and this bone is quite vascular. But the important thing is to make sure that you have a good landmarks, and once you know the position of your carotid artery on either side, you can decide how far you have to extend. The advantage is once you remove the dura in front of the tumor or the clival bone, you have essentially devascularized the whole tumor. And once you devascularize the many tumors, you can see they become very soft. In this case, once the tumor is soft, it is a fairly straightforward operation to debulk the tumor. But the important thing is that while trying to remove the tumor, one has to be careful. This is a left vertebral artery. You can see that perforator coming and going along the arachnoid layer here. So while trying to dissect off that arachnoid layer, one has to be very careful about not to pull this off. And making a hole in the vertebral artery, it's a difficult situation to manage sometimes. So the pull should not be this way. Try to push it towards the artery often to avoid pulling off these branches. But otherwise, these operations are fairly straightforward, and often you may need slightly widen the opening to get more vision. But once you go inside, you have a fantastic panoramic view to see it. Here I see that the tumor is extending below my initial exposure. So I decided to go below here and try to remove the lower part of the foramen magnum, which has got a thick tissue. And also the upper part, the foramen magnum also gives attachment to the ligaments from the odontoid process, like apical ligament and pectoral membrane and anterior and posterior longitudinal ligament. All these ligaments will be recepted. But as long as you do not disturb the atlanto-odontoid joint, the stability may not be a concern. Here, that is being resected further down so that you can consider the. You can see that this is the upper tip of the odontoid process, and atlas are intact. But we have taken off the foramen magnum here. There is disturbance of this lower part. But the main joint, the atlanto-odontoid joint, and the main ligament, which is the crucial one for the stability of the atlanto-odontoid joint, the transverse ligament, is preserved. So there's no need to stabilize such patient. Obviously, when you resect more, then that patient will often require posterior fusion. Here, there is some leftover tumor here, and that is at the cost of not disturbing this joint. But that is not the main concern. Our main intention was to debulk the brainstem so that he will become symptomatically better. And he remained well for many years. But subsequently, we saw this was growing back, and he was to be given radiotherapy later on. What about chordomas, which are more common tumors we approach through transclival approaches? It can vary from in terms of the size and the location, it can vary. You can have a very small tumor destroying the clival bone here. Sometimes the intercarotid distance can be quite narrow. You have to work between it. So there can be so many variations. For one case is like this. It's a young lady came with just CSF leak. And when you do a CT scan, you see there's pockets of air within the head. And all you see is that destroyed clival bone here. You don't have any solid tumor on the scan. You can see that the upper clivus and the middle clivus is all eroded, almost like a moth-eaten appearance by the tumor. You don't see actual solid tumor, but it was a spontaneous CSF leak. And she had this MRI appearance. This is before the operation. You can see, just remember the position of the pontine prominence here, and you don't see any tumor, but there's some enhancing tissue here. Obviously, you don't see tumor, but we know that this is a disease process. So it is important in young patient to go for a radical resection. And once you resect it, it's also important to try and repair that big hole you made. This is several years later after her treatment with surgery and resection. You can see the basilar artery and the pontine will be projecting into that cavity. So often we try to pack it in with fat graft and fasciolata graft so that you can avoid a significant pontine herniation or a basilar herniation. So another example, again, man, he's the late 70s. He did have a pacemaker, so it was always difficult to get him an MRI scan each time. But this tumor initially wasn't sure what kind of tumor he had, but it grew in a short period of time. So obviously this was a more locally aggressive tumor coming from the mid-clivus, projecting into the brainstem. And even though he was medically not a great candidate for a surgical operation, he needed an operation to, first of all, to diagnose the condition, also to secondary to excise the lesion and decompress the brainstem. And in such cases, you do resect the clivus, but this is purely an intradural, not purely, but part of the tumor was attached to the clival bone, but also most of the tumor was intradural. When operating such lesions, the complication that can happen, you have to keep in mind. One is the sixth nerve, which goes laterally, intimately related to the capsule. The tumor is ensheathed in the arachnoid layer. And this is not like an extra-arachnoidal tumor. This is an intra-arachnoidal tumor. So that's why it is so much attached to the sixth nerve. And important thing is that you use this is ultrasonic suction aspirator going on. Careful where you have the aspiration near the sixth nerve. And just as in brain transcranial operation, the general principle you have to employ is that you don't tend to move the neural structures. You keep it as stationary as possible, but you move the tumor. So you don't want to pull it away from the tumor. You want to pull tumor away from the nerve, not the other way around. And you can see that the tumor is quite big intradurally, but also firm and rubbery. Some of the chordomas can be very soft. You can see just the vertebral artery or the basilar artery lower down there. And this tumor is intimately attached to the arachnoid of the sixth nerve. So I don't want to pull it too much. So I'll be just giving traction to the tumor and try to keep the tumor, the nerve stationary. And this part of the nubbing which goes more laterally under the sixth nerve, and that is being generally peeled off. So the dissection of such neurostructures, either be a sixth nerve or a perforator from the front of the brainstem, that has to be done under direct vision. This is why it's so important that optics is a crucial thing in endoscopic neurosurgery. You've got to have a great vision and good optics so that you can do this sort of operation. Here, most of the attachment has been dissected off, and tumor is quite still very tough, but you can see the perforators from the front of the brainstem, and now it's generally being removed. What you get at the end of the operation is the appearance like this. The basilar artery here, and you have the basilar apex, the top of the basilar here, with the posterior cerebral artery, the P1 here, and also you have the superior cerebral arteries. In this case, it's an anatomical variation where you have the rostral trunk and the caudal trunk of the superior cerebral artery, early bifurcation. And you see this third nerve higher up. Obviously, the tumor was slightly being pushed into it. And here the sixth nerve is lower down here, all the perforators intact. These perforators are so crucial, especially in front of the brainstem. You have the short circumflex arteries and the long circumflex arteries coming from the brainstem. And when you remove these tumors, one got to be really careful not to injure them. So this is the immediate poster of CT, because we could not get a MRI scan because of his pacemaker. But unfortunately, he did well. Even though he did well for some time, he had an early recurrence and eventually went on to have multiple recurrences in different parts of the brain, and despite having further adjunctive treatment. So this chordomas can be a fatal condition in the long term, and especially in young patient, a radical resection, whenever possible, should be attempted. Similar case is another old man, a recent past, I think last year, middle of last year, with another tumor, which is coming from the upper clivus. Often the question comes whether you have to get a biopsy initially to diagnose. I think it is sensible to get a biopsy if there is any confusion about the diagnosis. If it's all clear-cut, then you can avoid a biopsy, because there is a concern when you do a biopsy. Obviously, you are using some biopsy, and there's that possibility of seedling along the biopsy track. So first surgery will be much better if you have a firm diagnosis. And in this case, bone is quite involved, and the bone is being drilled off, very vascular bone. Here, the soft tissue tumor is being peeled off from the arachnoid. The arachnoid, whether you have to resect the arachnoid, whether you have to leave some arachnoid, leave some dura, it's a judgment call one has to make. Sometimes when you may be able to peel off the tumor from an intact dural layer, but when the dural layer is affected, often it may be very reasonable to resect the dural layer. But again, that is a decision one has to make on table, because this man was having anticoagulant till 2 days before the operation, and he needed that anticoagulation to avoid his cardiac complication. And removing the dura and then repairing it and then possibly using lumbar drain may not be a good idea in such cases. So this is a case where one has to decide whether I can just remove the outer layer of the dura where the tumor is involved and avoid breaching the dura, so that you can avoid a lot of other complications. Because once you breach dura, once you resect dura, then it's another level of operation. Here the tumor is being removed from the upper clivus, and you can see that this is the carotid artery on the right side. The paraclival carotid is de-roofed, and then one has to go around the carotid artery to remove any tumor fragments. So this is all exposed here, and you can see that I can push the carotid artery to one side to get under the carotid artery. On the other hand, on the other side, also I'm resecting this tumor from the dura. It's not completely free. This is all soft tissue in front of the dura. That's the cella up here. This is cellular flow. I'm just splitting the dura so that I can take off the upper layer. So in this case, I prefer to avoid entering the inner layer and breaching the dura, so that I can avoid a lot of other complications. So the case has to be when you want to resect the dura, when you don't want to resect the dura, is something which one has to make at the time of this. Obviously, you want the tumor to be resected away from the brainstem, because for sending this patient to proton beam, one needs at least 3 millimeter space between your tumor and the. So in elderly patients, one may have to make a decision to remove the inner layer if needed. This is another case. Here the tumor is coming all to the brainstem. My intention was to remove it. And often these patients will require, this is post-biopsy, you can see the adhesions inside the nose for after the initial operation. Here the nasal septal flap is being harvested. It's important that you have a good flap. And once this flap is resected, the other opposite side of the mucosa is turned around like a reverse flap, and the affected bone is being drilled off. And here the dura is mostly intact. This is the posterior clinoid on the right side is being removed. in chordoma patients, the posterior clinoid is often eroded and it may be easy to remove. But in some patients where you have a concern about the posterior clinoid, one has to really lift the pituitary higher up to expose it and drill it off. Pulling on the clinoid often can lead to possibility of traction on the sixth nerve, so the one has to be careful about it. So we'll carry on here. In this case, I found the inner layer is slightly breached. The arachnoid is inside here, outer layer is intact, but there is an area where the tumor was attached. So to give a complete clearance, I opened the dura and I cauterized it and then made a bigger hole and cut it open and then finally repaired it with the fascia lata and the fat graft to fill up the clival defect. And this is the big flap you use to cover it. So push forward. Then the one thing one has to remember that when you request postoperative MRI scan, mention the kind of repair you use. Here, I can see that fascial layer graft is not the tumor. So the radiologist may not know about it because they may report like a residual tumor, and that has implication in terms of eligibility for subsequent proton beam treatment. It's a young patient. Again, in a year ago, I think, a lot of tumor going into the posterior fossa and the middle cranial fossa. So such tumors is important to plan meticulously. Here, the main concern for you is to avoid a complication related to the carotid artery. You can see that the left cavernous is completely invaded. The carotid artery is being splayed. A lot of tumor into the posterior fossa. Just to compare the two carotids, the right carotid on this side can see the petrous carotid here, the cavernous carotid. You can see this cavernous hyphen endon view and the supraclinoid carotid. If you compare that one with this one, petrous carotid, then the entire cavernous carotid is being splayed and opened up. This is a supraclinoid carotid. So this is like the kind of shift of the carotid and the change in the anatomical pattern with such large tumor. A lateral view of the same carotid. Here you can see the carotid is all being stretched up. The only 2 points is tethered is the entry into the petrous canal and the dural ring, the distal dural ring, where it is behind the clinoid. So apart from these two fixed points, the rest of the carotid is being opened up. So the important thing in such cases that you want to avoid a carotid damage, and one has to keep in mind the possibility of a carotid rupture. Even though the tumor may be soft, when you want to try and resect it off using curette, you can scrape off the tumor around the carotid, but these branches may be somewhat brittle and more fixed in terms of their maneuverability, so that it can easily cause a hole in the carotid. And it's important also to prevent a possibility of a stroke if you have to consider endovascular sacrifice of the carotid. So if you do preoperative balloon occlusion test in such cases to avoid. So this is the initial postoperative MRI scan, and you can see the packing and the brainstem was being flattened out by the tumor for some time, but this will recover. All this will shrink down and settle down. There's some new pneumocephalus, and I think this is after 6 months. You can see everything is settled down, and you can see the flap that is being used to repair the medial fossa defect. I'll just track on. Similar cases, chondrosarcoma. Slight difference is that it is more lateral, so it may be behind the junction of the paraclavicular carotid to the cavernous carotid. So it may be going more to the side. If there is too much tumor lateral to it, it may be inaccessible through your endoscopic route. One may have to think about possibly a lateral route here as well. But the tumor is fairly soft, and it is not a difficult operation in many cases. Again, the extent of resection and how much you expose and how much you resect all depends on case-to-case by basis. The primary intention is to resect them completely. And sometimes the disease process is uncertain. You don't know what it is. Initially biopsied by another colleague could not get a diagnosis. And this is all like a thickened dura around the lower clivus or more laterally towards the internal meatus. And there were a few possibilities to consider. One may have to consider meticulous planning, why the initial biopsy was negative, So this time I went more lateral to the initial biopsy. There's the endoscopic view on the right side. There was a scar from the initial biopsy side by the colleague. And this is being resected more laterally to get a sample. So I think it's almost 45 minutes. I'll stop here. Mainly, I wanted to make sure to give a take-home message about these cases. To avoid complication, you've got to have a meticulous planning and find out what is your main concern about the complication. Think about the complication during the operation and have some backup. For example, if you have a carotid damage, you've got to have some backup to try and treat it. And often, all these patients will require a team approach with your colleagues, neurosurgical colleagues, with your ENT colleagues, with your endovascular colleagues, and the oncologist to give the best outcome for your patients. I will stop sharing now. And thank you for this invitation, and I am honored by it.
Thank you. Thank you, Dr. Ramesh Noor. So yeah, very informative and very good explanation, and really exciting. There any questions or comments from the audience? All right. Any questions or comments from the audience? So I would like to ask you about the somebody.
No, go ahead, Takashi. Go ahead.
Okay. Yeah, I want to ask some things with the lower clavicle part. So it's very difficult to see, and the skull bone is so thick, so very difficult for drilling, and risk of complications to injure basilar artery or some other perforators. So to avoid this, your tip is are there any tips to avoid the complications or drilling?
So even though the lower clavicle bone is very thick, the risk of damaging the basilar artery or perforators depends on the type of case. If it's a tumor affecting the clavicle bone, obviously, if the dura is intact, there is no risk. I agree, it's very thick and can be very vascular, and your ankle is slightly different. You may have to have a slightly wider exposure on the outside to have both instruments in. Otherwise, in such a narrow space, you will be competing for the space with your endovascular and with your colleague who is holding the endoscope. Your instruments will be moving around it, and you may not get. So to avoid that, my advice would be to try and maximize the exposure outside. Along the edges of your exposure, you get more space so that you have a great position for the endoscope. And once you remove the clavicle bone, and there are two approaches to go inside. Once you take off the dura, there are two ways to. One, you can remove the outer layer of the dura. Obviously, the basilar plexus, which is a very significant venous plexus, and give you a lot of bleeding. And if you try to go in one go by cutting the two layers around the pathology, you find that you'll have a lot of bleeding and a lot of bleeding going intradural space and then obscuring on the anatomy inside. But it may be a good way to go about is to take off the outer layer of the dura first. Obviously, you'll encounter bleeding. Then you keep controlling the bleeding using several techniques, bipolar or even using flow seal, and then cover or at least obliterate all the sinuses so that you have a clean inner layer. Then it's like a craniotomy operation. You then open the intracranial dura, inner layer of the dura, so that you have a pristine or undisturbed intracranial space where you have a good vision for your tumor and your basilar artery. And third thing, I've already mentioned in one of the cases of the meningioma, where when you want to peel off the tumor from the vertebral artery system or the basilar perforators, the pull of your tumor got to be careful. If the tumor is if the basilar the perforator is coming medially and you're pulling away from the parent trunk, obviously there is a risk that you can pull it off the main trunk. But if it is on the other side of the vertebral artery, if you're pulling it towards the main trunk, then the risk of causing a problem is less. So the pull of your tumor got to be careful and try to avoid pulling it away from the main trunk. That is the main point I wanted to make to avoid damage to the perforators and the main trunk. And chordomas obviously can, if they infiltrate into the wall, they can make the wall a bit more brittle and more friable and vulnerable to injury. So one has to be careful while trying to scrape it off or trying to shave it off from the main artery, especially the carotid artery in the chordoma patients.
Okay, thank you. Thank you so much. Thank you so much. Are there any other questions?
There is one question, just saw it on the screen. When you must change scope to 30 degree. So that's a good question because once you go to the sites, midline clival recession and midline tumors, you can often manage with 0 degree. We find that 0 degree may have a slightly better, most of the units may have a slightly better optics when you use a 0 degree. But when you turn to 30 degree, that optics may not be such good as the 0 degree. But still, 30 degrees is a fantastic endoscope, especially if you want to go slightly more to the sides, and you may be again competing for the space if you're using a 30 degree, if you're using a 0 degree. So if you're using like an angled instrument or angled suction, it may be safer to use an angled endoscope so that you can look around the corners before you try and resect such lesion.
Okay, thank you. So, other questions? Any other questions from the audience? Okay, so we'll conclude the lecture. Thank you, Dr. Ramesh Nair, for wonderful lectures.
Thank you. Thank you very much.
Thank you very much.
Thank you.
Okay, I think Wan Lee, are you there? He's going to be introducing the next speaker. Hello, Wan Lee. Are you there?
I'm here.
Okay. Okay, I guess I'll introduce you. Yes, Professor Zhenchao Wang is working in research in neurosurgery at the same hospital as Wan Lee, Beijing Tiatan Hospital. Welcome, Dr. Wang. It's all yours.
Thank you. So I should share my screen first. And good evening, dear friends and all the professors and the audience online. I'm Wang Xingchao from Neurosurgery Department of Beijing Tiantan Hospital, and I really appreciate having these opportunities to communicate with all of the audience. And I thank you to the Ramesh, a very nice president. As actually, I'm also a specialist in endoscopic neurosurgeries. Maybe next time we can talk out of online and change our experience. Okay. But nowadays, I want to share some works about neuroscience research in the neurosurgery department. So I want to begin my presentation of these famous paintings and screen and named The Creator of the Atoms. So it describes the very moment that the God gives the human the spirit or the intelligence to become the human beings. But no offense, let's focus on the right part of the painting so we can see that the outlines of the God is similar as the sagittal cart of our brains. Actually, this story is not made up by me, but comes from a very popular American series, Westworld. In these stories, the robot had the help with the help of AIs and have their consciousness to go against the humans. So we can maybe we can explain that the brain make our human difference. So the brain is dominate rooms in our lives. So in the technology is developing very quickly. So now we can explore the deep space and get the far lateral planet pictures and use the scopes to discover the signals all over across the universe. But when we look back to the neuroscience to study our brains, there's also studies we want to call it microns. It's the reverse engineering to reverse engineering 1 cubic millimeter brains of a rat. So compared with the fascinating project of the space, we prefer that neuroscience may be the last frontiers of the science. how the consciousness comes from and how the brain works is puzzles for centuries. But even it's the last frontiers of the science, but it's not the new topic for us. In ancient China, they also think about what make us think and what dominates our bodies. So they explain that life is made up of essentials, and they also call it spirit. We can see the Chinese characters Jing and Shen. It's come from the thinkings of how the brains and how we thinking and it comes from. And in the ancient Western countries, it has a more systematic analysis, research of the brains. At the 3rd century BC, the ancient Greek philosophies to begin thinking about the mind. Then it's a very abstractive concept. And because of the lower productivities and the technique batteries, so only when time come to the 16th centuries, we have the first concept of brain anatomies. And also in the 17th centuries, Thomas Wills invented the word neurology. So from that on, we can study our brains scientifically. And the most important, maybe we should remember, is in the late of 19th centuries, the Broca and Wernicke, Dr. Broca and Wernicke, discovered the brain areas responsible for the speaking abilities. So as we're familiar with the Broca and Wernicke areas. So from that now on, the concept of functioning localizations of the brain was formed. And from that on, all of our works is to mapping the brains, how the brain works and which part of the brain takes responsibilities for different functions. And nowadays, the increasingly research has occurred in these areas. For us, the clinical medicines, the precious anatomy, and the different treatment for these different conditions has been come out. And in the biological and psychology field, we can now use the different tasks to estimate the learning memories, conscious, and so on. And we can give examples later. And nowadays, also the brain-like research is very hot. The artificial intelligence and the brain-computer interface is also we want to take part in. So nowadays, the great economic groups such as US, Europe, and China and Japan has begun their project to study the brains. And in 2022, China also began the Chinese brain project to know how the brain worked and use it to the intelligence, artificial intelligence, and also to cure the disease. So for neurosurgeons, what can we do for these big and fascinating works? Actually, our pioneers has given our examples. At the very beginning of the brain science, so many neurosurgeons have made outstanding contributions, such as Harvard Cousins. We know that is the founder of the modern neurosurgeries, and it also built up the neuroendocrinics. And Penfield is also the founder of the brain functional zonings and mappings, how the brain works. And the Moniz, he used the instrument to disconnect the connection between the two hemispheres and to deal with the different psychological conditions. Although it was wrong nowadays, but it proved that the brain functions and our cognition processings can be manipulated by the surgeries. So nowadays we face to brain traumas and brain tumors, and it can do harms to the structures of brain dramatically. However, all of these patients were alive and they will have different conditions. So from these resources, maybe we can do different research and to help the developing of the brain science. So at the last part, I will take some time to present 3 parts of our works, start from 10 years ago. So some works are very interesting to help us to know how the brain works. First one is lesion study parts. as all we know that we neurosurgeons deal with the different lesions in the brains. So in this part, we use the intracranial tumors, and before and after the surgery, we can get the very focal lesions of the patients. And so we can use these different, very unique models to explore how our brain works. So nowadays, the most popular way to know the brain works is the neuroimaging, different types. So we use the NIR, ERPs, or PETs, or so many different technologies to get the signals from the brains. However, this kind of different technology help us explain our study field and the topic dramatically. And also it can deal with the healthy peoples and give us so many new ideas of how the brain work. But however, all these different technologies are just not directly get the structures and not directly get the causing relations between structure and function, but get the related relationships, such as the most familiar one was functional MRI. It has been developed for 30 years, and it's based on the different analysis process and use the processings to interrupt how the brain works. But however, once we change only a little analysis parameters, we can get different and even opposite results from these kind of studies. So the gap between data and the realities is huge. Is there any way to know how exactly the brain work and the structures for the functions? Actually, we can use lesion studies. Lesion studies is not a new technologies, as we mentioned previously, and the Broca and has used brain lesions patients to know how the brain, which part of the brain is responsible for speakings, and know the Broca areas. Actually, for the prefrontal cortex and the fundamental for the decision makings also began from a lesion study. We saw that before. That is a patients get injury in the frontal cortex, and the series of tasks to examine these patients start the decision making areas. And there's also a very famous patient called HM. And all of this study focus on these hippocampus lesions, give us the basic understanding of how the memories works. So in our studies, we combined with the neuroimage and lesion studies to make us the story complete and get the whole views of how the brain and what is the really relationship between special brain part and the functions. So that is examples that we published 10 years ago. We want to know how the peoples get empathy. This means how can we feel or share the feelings and emotions with others. It's very important to get a group and to build up our societies. At the first part, we build up tasks to activate the empathetic processings in this task. In short, we ask the participant to judge whether the hand or foot is painful or non-painful. And in the second part, we ask the patients to ask the participant to answer this part, this leg or hand, or right side or left hand. So use the different data analysis, we can take out the empathetic signals. As we can see in the right part in the fMRI, you can see that the anterior part of the frontal and the anterior to cingulate carot, and the motor areas was activated. In the classical researches, this story is closed. So we can say all of these areas related to the empathetic processings. But the question is whether all of these three parts is critical for empathetic processings. In other words, these three parts all take part in the empathetic processing is unknown. So in the second part, we use the lesion studies. We find different patients and has gliomas, has very similar locations with areas in the activation during the empathetic fMRI. So, and we separated them to different parts, different group, the anterior insular cortex group and the anterior cingulate cortex groups. And we also use the other related brain tumor locations patients as the brain damage controls. And by compared with the different behavior performances of these four group, the normal control, the brain damage control, and the anterior insular and the ACC, we can find that only the anterior part of the insula was removed. They can get deficits in the empathetic pain processings, and is more obviously in the implicit empathetic processings. But however, for the brain damage control and ACC group, they do not show the same patterns. And in other words, only remove of the anterior part of the insula will damage empathetic pain processings. So we can get the conclusion that AIC is critical for empathetic pain processings. Use the same philosophies. We also estimate the patients of the insular glioma patients pre and post operatively. We can find that only the anterior part of the brain was removed. They will affect their empathetic processings. So it's also going to help us to give a very deep estimations of the patients pre-operatively. As this, also we use this kind of strategies to studies the more complicated social decision-making processings. We use the ultimate game between two peoples, and one prefers proposals, and the others determine take it or leave it. And so we also use the fMRI study to find two parts, the insular and the VMPFC, ventral medial prefrontal cortex. And then they also let them do the ultimate gambling task. And we can find that only the insular cortex damages will damage the adoptions of the patient, of the participant to leave it or take it. And so we know, and from these studies, we can propose that the insular and VMPFC take different response in the norm adoptions. And also, so we want to know how the brain, why the insular is important in this sophisticated processings. One of the explanations is that insular is an interface between the outside world and our in-body signals. So the outside signals and our in-body signals has a different mean values. So the different values between these two signals will drive us to make different situations. To prove these proposals, we also set up different tasks to know how the brain gets the interceptive informations. We use the interceptive attentions as we ask the patients to focus on these lines. There are brief curves, and we want to judge whether the line is delayed or non-delayed. And also the red spot is the outside attention signals. And in short, after the analysis, we can find that only the anterior part of the insula take part in the interceptive attention processings, and also the activation values is positively related to the performances of this behavior performance. And once again, we use the different patients with brain lesions in anterior part to confirm that only the AIC is necessary for the interoceptive attentions. So I also use different tasks to detect other part of the brains, how that works for. And some ongoing work focuses on the attention capacities and also the different judge of the values. And also we can find different part of the brain's works. And this is papers that are very interesting. They get the different colors to estimate that which the brain areas get the highest effectors published. So you can find that the insular and the middle part of the brain areas is most focused on. It also can guide our further works. And the second part is brain tumor studies. We can know that brain tumor is one of the most important disease we deal with in every days. So for this different brain tumors, it's also very unique models for the brain science research. At the first part, we can know that the different brain part responsible for the different brain functions. So we can say that brain has a functional separations. But however, the brain has more than 1 billion neurons. And how the brain can deal with the complicated signals, one of the explain is that the brain connections make the contributions. So we can say that brain is a very efficiency and energy saving super processors compared with the super computers. We can see it's very light and it's very energy savings. When we compare the transmission rate between the brains and the super computers, the brain is 30 times faster than the supercomputers. So which structures support this kind of super processors? One of the plan is the brain connections, and so some of the researchers have focused on that. The patients will suffer the perioperative brain function remodelings, and we can find there are so many different parts, and the connection between each of them has been changed then perioperatively. So it gives us a spark that we can use the brain tumor patients to get to know how the brain plasticity, how the brain fits the different conditions and how the brain plasticity occurs. So in this part of work, we use a very we were very familiar tumors, vestibular schwannomas, to know how the audience auditory cortex plasticities. We always know that the patients once have the vestibular schwannomas will suffer from a postlingually unilateral hearing impairments. It's the most important conditions for these patients. So we want to know once the unilateral hearing impairments, how these conditions can affect the central nervous systems and lead to the different brain plasticities. And after we use the resting states fMRI to detect the difference. First one, we analysis the whole brain connectivities. We find that we use parameters named reholes. It means 1 voxels and the surrounding 27 voxels, and we compare their activities. Once they have the same activities, the values will be lower. And once the rehole values is higher, means the surrounding structures has the different functions, and not the functions is not focused on one. So we can find that for the whole brain red holes, also very interesting, the anterior part of insula and the visual cortex has the significant differences. And then we use the anterior part of the insulas as the seed to analysis the every different connectivity between this seed to the other part of the brains, and analysis is different. We can find also it has different part connectivity with the right PCG, right ACC, and MPFC. And when we look for how this brain works, we can find that all of these areas was deal with the cross-model signal input and processing. So in other words, the connection between the brain itself is weakened. However, the connection between the brain and the outside world and the cross models such as audio and the visuals has been enhanced. So it gets the data support for that. Maybe the deaf can see better. So this is we can find and use these vestibular schwannoma patients. And also it's not leading to the different connectivity plasticities, or also analysis the structure differences between the vestibular schwannomas patients. We deal with the two parameters focused on the two parameters. First is hearing abilities, and the second one is hearing loss durations. We can find that the primary auditory cortex has been decreased when the hearing ability is decreased. So it's very easy to understand because we cannot hear, and so the primary audio cortex has decreased. But very important is the structures involving high-level cognition control functions, such as the middle eyes and the ACC part. The decreases is related to the hearing loss durations. So it's make clear that long time of the hearing loss duration will leading to a more wide and more serious damage to the brains, not only to the primary auditory cortex. And so that is also a very interesting findings. And also we can use the pituitary adenomas to deal with the effect of the optic chiasm. So after the tumor removed, the vision impairment will have become better. So we can deal with the pre and post-operatively different visual cortex signals. We can say that also the pituitary tumors models give us an insight, know how what time we should remove the tumors to stop the plasticities of other lesions, other areas of the brains. And also, so we can analyze the vestibular schwannomas will have a temporary facial paralysis. And for this very special phenomenon, we can use it to know how the emotional occurrence. That is one theory explains that the emotions come from the muscle system has a mimic series to mimic the other patients' muscle facial movement, so that give us the emotions of different emotion recognitions. So for these patients, we can know that we can use these different models to know that once the facial paralysis will lead no problems of emotion recognitions will support the mirror neural system series. This is also we can use from the tumor patients. And we not only observe the tumors and it's leading to the different conditions, we also to rebuild and reconstruct the neuron constructions and to have patients get the better health. So we informed the first and only auditory brainstem implantation project in China. And for the animal mode, then we get the equipment development, and then we use the awake acrylatomies to make sure that we put the ABI to the right places, ask the patients to answer the questions, did they hear the voice or the voice is high frequency or low frequency to help to adjust the placement of the ABI more precisely. So the third part and also the last part is we also have some neurosurgical very special disease. So use the neuroscience strategies, we can know more deeper how these special disease studies happens and how can we help with these patients. So now we build up the neurosurgery system hereditary tumors groups, and we compared with others hospitals and institutes to get individualized the precision treatment programs. So most we can have the example is the neurofibromatosis type 1. So that is a very rare inherited disease, and however, it can put serious boundaries in the daily lives. There is a very unique models to study the mechanism of the cognitive control processings, because some of the patients will have a difference in the working memories. So at the first part, we want to know how the brain, how the patients get the, is there any difference of the patients during the attention processing? So we use ANTR task. In this task, the attention has been separated into three elements. First is alerting, the two is orienting, and the third step is the executive controls. So we ask the NFM participate to deal with to complete the ANTR task and analyze their behavior data. So we can find that for alerting and orating the first and second steps, the patients have no difference with the normal controls. Only in the executive control time, even the third step is more complicated. The NFM patients have suffered deficits with the normal controls. So we can see that there are the separated deficits of the attentional processing for NFM patients. It can also explain why most of the patients do not report they have difficulty in studies or in the daily life. However, some of them will have the lower grade scores in the schools and cannot get the better education's results. So because the disease affecting their high levels processing, but not affect the basic behavior performance. And also for the working memory part, we use two types of unback task to estimate. First one is the latter working memories, and the second one is the visual spatial working memories. We can see for the this is the back for the verbal working memories. Ask the patients to record the letters they can say one or two before the present ones. So we can say there's no difference from the patients and the normal controls. The working memory seems intact. But when we ask them to remember, to record whether these positions, the letters have been presented, they have a very significant decreased with the backward is increased. So we can say that also they have the separated working memory deficits and leading the a more sophisticated conditions. And all of these conditions was related to the dopamine enhancement areas. And we also want to use the PET to know whether our proposals is correct. Based on these two part of studies, we can know that NF1 patients has a very unique cognition deficits. Some of the patients should be pay attention even for the young and the children patients, and not only focus on the other conditions, but also should pay attention to their condition, their cognition process. And as we also mentioned previously that we are from ablation to interventions now. So ABI is one of the examples, and it can help us to get the neural instructions. And the DBS is more familiar with us, and we can use it to do the neural regulations to get the better know of our brains. So for the further works, we can use the platforms combined with neurosurgery and neuroscience to recognize the special brain functions and explain how the studies can be performed. And the second, based on this data, we can get a better protect of the brains. And last, maybe we can restore the complex brain functions in a more better ways. So that is my my tutors and my lab mates. And that is some related papers you can check with the details of the previous studies. And thank you, that's all.
Okay, Takashi? Takashi, you there?
Doctor, thank you, Dr. Shin-Chao. And I ask you some questions. Is there any questions from the audience? Any questions?
People are shy, Takashi. Oh, go ahead.
Okay, so any questions? So, okay, so yeah, the research mind is important. So what do you conduct in the future based on the knowledge of the experiment? Your future plan around the future plan, or that there's neurology or neurosurgery?
Yes, thank you. Actually, the future plan is based on two parts. First one is the observations. So we can also go use the unique models of our human patients with brain lesions to know how the brain works. And it cannot take place by others such as the rat or the mechanism studies. We should know how the brain exactly the brain human brain works. This is the first, and the second is we can take to the deal with the brains, manipulate the performance by DBS or other kind of instrument to have the interface between computers outside the world to the human brains.
Thank you. So yeah, interface and the rat model, so the experiment model is very exciting. So I expect for future development of the studies. Thank you, Dr. Shin-Chao.
Thank you.
Okay, thank you, John. So can I conclude? Can I conclude this session?
Yes, looks like thank you very much, Takashi, for moderating. Thanks, Dr. Wang and Dr. Ramesh Nair, an old friend. And we will not be having the webcast in 2 weeks. I guess there's a holiday in China. But I'd like to say hi to Ahmad Farzad from Afghanistan. Do you want to say hello?
Oh,
hello. Thank you very much. Shishi.
Okay, and like to say hi to.
From Afghanistan, yes.
Very good. Welcome.
Excellent webinar. Thank you.
Thank you.
Yeah, I'd like to say hello to Eskander Munder. Do you want to say hello, Eskander? You got a good connection, looks like. Go ahead, Eskander.
Hello, guys. It's a pleasure to meet you all. It has been a wonderful webinar, although I didn't have a wonderful connection, but I'm sure I'm going to be able to see it all on your YouTube channel. So thank you for contributing, John.
Well, where are you from, Eskander? Where are you from, Eskander? I guess you must have.
I'm a surgical resident from Syria.
Okay, welcome.
Syria.
Welcome.
Okay. Welcome.
I hope to see you again. Okay, we'll see you in about a month, everybody.
See you. 2 weeks after. Thank you.